Good afternoon. I call Human Services Finance Committee to order. Members, we have a quorum
Chair,
present.
I think this is on.
That's what I'm trying. Something is missing. Mic check here. I think there's something wrong. We're good. Good afternoon again. I call Human Services Finance Committee to order. Members, we have a quorum present. We have few agenda items today, and we will get started. House File 47, Representative Bierman, I see you already there. I'll move the House File 4047 to be laid over. Please introduce the bill and proceed. Oh, go ahead.
Okay. Thank you, Mr. Chair, committee members. Thanks for hearing House File 4047 today. Members, last year we made important progress in getting kids with medical complexities the home care nursing services they need by investing in rates to increase wages. Pediatric Home Service, as a single provider, has been able to hire 10 new home care nurses since rates went into effect in January of 2024. The investments we made are making a difference. There is still much work to do to get kids who need home care nursing services the level of care that they need and their families need. Now, I know you in this committee have talked a lot about hospital decompression. This bill is one creative solution to help get pediatric patients who are waiting to be discharged from the hospital the appropriate level of care they need at home, in turn alleviating some of the pressure on our children's hospitals. 95% of complex pediatric patients in the queue are medically ready for discharge from the hospital to their homes. The average discharge delay attributed to lack of nursing access is 90+ days, costing approximately $450,000 per child. This proposal is a pilot program that is based on similar, measurably successful programs in other states. It would invest $1 million over 2 years to develop and implement a program transition team, or a program that is hyper-focused on facilitating pediatric hospital-to-home discharges with a nursing transition team, hospital competitive pay, and incentivized staffing consistency. This will be done in coordination with Fairview Masonic Children's, Gillette Children's, and the Children's of St. Paul in Minneapolis, and the Minnesota Department of Human Services. The program aims to reduce the following measurable metrics: delayed discharge days, avoidable rehospitalization days, unnecessary emergency department utilization, and the number of school days missed due to lack of nursing. It also aims to improve family and caregiver capability and resiliency and the comfort level and competency of nursing staff. A report on these metrics, including an estimate of the return on investment of the pilot program, will be prepared by DHS in December of 2026. No one should live in a hospital who does not medically need to be there. A hospital is not a home. A hospital-to-home pilot project will help reduce avoidable days, free up beds for other patients, increase staffing resources, and most importantly, bring kids home to their families. Members, there are 2 letters from doctors in your packets I would like to draw your attention to, and I also have Cameo Zender from Pediatric Home Services here, who can give more details about the program and answer any questions the committee has. Mr. Chair, Ms. Zender's coming up.
Ms. Zender, welcome to the committee. Please introduce yourself for the record and proceed.
Hello, Chair Noor and members of the committee. My name is Cameo Zender, and I'm the Chief Administrative Officer with Pediatric Home Service. We provide hospital-level care to medically fragile children in their homes, including home care nursing services. I can't go any further without first saying thank you for the increase that Representative Bierman described from last session. That increase took effect on January 1st. We spent the fourth quarter of last year passing 100% of that increase directly to our nurses. And we are seeing the positive impact. 10 nurses equals an 8% increase in the number of nurses we have available to staff children in comparison to where we were at the end of 2023. While the needle is moving in the right direction, we're still far from a full tank. And House File 4047 does something different. It gives us an opportunity to prove what we've been saying for way too many years, that an investment in home care services delivers better outcomes for children and reduces the total cost of care to the healthcare system. The pilot program invests in pediatric hospital-to-home discharges, made possible with the nursing transition team, truly hospital competitive pay, and incentivized nursing models. We know that hospital salaries, even with the increases we were able to put through, are still 25 to 30% higher than what we can afford to pay our nurses choosing home care. And children remain in the hospital unnecessarily on average for an additional time of 3 months. We were able to support kids like Mateo, who you may have been introduced to through one of the handouts. Mateo and his mother, Maribel, were able to join me in the Senate hearing, the recent Senate hearing, only 6 days after we were able to bring him home from the hospital. They're not able to attend today, but I promised Maribel that I would share some of their story. So in her words, I stayed for almost 10 months in the hospital with my son. He is oxygen dependent and uses a ventilator. It still makes me sentimental, the fact that I can have Mateo home with me now. In November, we talked about a hospital discharge, but the hospital couldn't let him go home because I don't have family near and there was not nursing available. We said that Mateo cannot grow up and spend his entire life in a hospital. We started looking for nurses in January to help Mateo get home. It was very sad that Mateo was ready to go home, but no nurses were available to care for him. On March 19th, Mateo was finally discharged from the hospital, and I can say that it is a great help to me and my family to have the help of the nurses at home. Mateo is one success story, and we celebrate him and his family. Pediatric home service alone has 30 more kids that are waiting for us to help bring them home. The pilot program will deliver evidence-based results so we can prove what we already know to be true: improved clinical outcomes, increased family support, and reduced total cost of care through the metrics that Representative Bierman described. PHS has a similar model in the state of Nebraska through a managed care plan. In its first year, we recently learned from the plan that they're showing a 75% reduction in ED visits for kids who have been transitioned home and a 65% reduction in inpatient days. The model works. I ask for your support to prove the same positive outcomes here in Minnesota. Thank you for staying committed to our families, to our medically complex kids, and the outstanding nurses that care for them.
Thank you so much for your testimony. Do we have anyone in the public who wants to testify on this bill? Seeing none, member discussions. New Burnley.
Thank you, Mr. Chair, and thank you, Representative Bierman. My questions are related to, I'm trying to understand a couple of things. One, I'm trying to understand exactly what this will be used for. It's actually really good to hear that with the increase in rates, we have been able to increase workforce, which really is our goal across the board. My question is, what kind of specific things would this be used for? I mean, it says that they can be used for administrative training and auxiliary services. What kinds of things might that include?
Representative.
Mr. Chair, I think I'll let Ms. Zender answer that question in detail. I've got some things I'd say, but I think you run the program, so I think she'd be the best
Ms.
one to
Zender.
answer.
Thank you. Yes, so the funding would be used most specifically for nurse compensation and allowing us to do creative things that currently are not available. So the nursing transition team is a model of nurses who are trained and skilled to be able to bring our most complex kids home. And with that, we are able to provide them with a complete stability in wage. What happens right now in the home care nursing environment is if the nurse doesn't have a patient, the nurse doesn't get paid. So some of that funding would allow us for the nursing transition team and other nurses to ensure that regardless of staffing a case, those nurses have consistency in their pay. It also allows us to do things like further incentivize nurses through the recruitment process, through hiring bonuses, retention bonuses, and then as well, as mentioned, incentivized models for staffing. So prior to COVID, we were able to staff our cases at a minimum of 90%. Right now, we're at 65%. So as well, that funding would allow us to continue to incentivize those nurses to not only commit to a schedule, but then carry through that schedule. And we're happy to further stipulate through the process exactly how that funding would be used to the committee's satisfaction.
Lead New Brinley.
Thank you, Mr. Chair. I guess I would be curious to know how the department would choose to interpret this language. On line 2.1, it says grant money must not be used to supplement payment rates. Now that very specifically says payment rates, and so perhaps they would view this. I mean, I think you described it as complete compensation and wage. Perhaps they would view that outside of that because it's not directly impacting rates. But I would be curious to know how the department would interpret that, and if they would be okay with that use. Sure. The way I read it initially is it would not be going towards compensation of nurses. So I do appreciate that. My other question, Representative Bierman, would be for you. I'm a little bit concerned about the report. Of course, I always love a report. But as I read the criteria for this report, it sounds like it's all assumptions of negatives, which I don't know how we quantify that in real terms. Number of delayed discharge days eliminated. Well, there's no way to really know how many days they would have been there without this particular grant. So I don't know how we quantify that, and each of these items has that sort of flavor to it. It's all asking for negative information, so it's completely speculative, really. Unless there is a way, and maybe that would be the question: is there a way to know these things beyond just speculation?
Representative Bierman.
Mr. Chair, Representative New Brindley, I believe, the fact is that we do have data on what we have now as far as number of days that kids are in the hospital longer than they need to be. So we do have a starting point, a basis. And so if we look at this project and we look at how many days the particular kids those days are reduced over time, I mean, that's going to be one impact in the positive. So that's one area. Rehospitalizations, again, this is recorded information, so we know. So we're just trying to bend the curve a little bit on these items. And so I think those are measurable. And then unnecessary department admissions eliminated. So again, those are things that we count school days. And so bending the curve down in any way, shape, or form would be a significant sign. And the department may have more to add to that, or perhaps Ms. Sender, but I think that's how I read the bill is we have a basis now, we know what those numbers are, and the purpose of the bill is to get kids home for better outcomes, which has also been proven, and we know that they need to have, eliminating these things have other ramifications to the hospital system.
Lead New Brinley.
Thank you, Mr. Chair, and thank you for that. And maybe you can just give us idea, how many we know for sure when it comes to decompression, how many kids are we talking about?
Representative Bierman.
I think, Mr. Chair, Representative New Brindley, on the pediatric home services side, they have 30 clients, I think, that are awaiting. I don't know what the system-wide is, though.
Lead New Brinley. Follow up.
Thank you, Mr. Chair. That is an interesting number. Since we know, I mean, it's such a low number, right? It's such a small number. That $1 million actually could, a relatively small appropriation actually could have an impact, which I do think is interesting. And I wish we would have spent this money when we had $30 billion last session. Thank you, Mr. Chair.
Thank you so much. Any other member? Chair Pryor.
Thank you, Mr. Chair. Thank you, Representative Bierman. I think that we're always talking about something important when we're talking about, reducing the number of days in hospitals and for all people, but particularly for children, bringing them home. And one thing that I was also interested in is it seems like this bill is right now, we are focusing on and should be thinking in terms of that transition back into the home care as being the primary focus. But then I also see that there's the idea of long-term nursing needs for pediatric patients. And so that being some of the data that's also collected, because I know there's this other issue, which is to always be on that line of whether or not it's, it's obvious for the child and for the family, it's better to be at home, or it's probably better to be at home than in a hospital setting. But will some of the data be addressing actually kind of that ongoing cost of preventing hospitalizations by better meeting nursing needs as something else, which is kind of that other question, which has been around because I do remember going to a home of one of my constituents 8 years ago, and somebody with very complex medical needs and needing 24-hour nursing care. And their idea being, they weren't, it was a more, a family that had more resources, and so they could come up with a difference of what they needed to keep their, at that point, almost a young adult, but teenager at home rather than in nursing. So will some of the data, do you anticipate that some of the data will be addressing that need, or is it more focused on this idea of how quickly can you get people with complex needs back home again? And what does it take to make that transit or that hospitalization back home again time? Just kind of like the scope of what we're doing right now.
Representative Bierman.
Mr. Chair, Representative Pryor, I think the scope of this one is specifically focused on the pediatric care. I mean, there's a lot of things that come off of this. Unless you have more information, I don't think it's beyond that scope when we go into looking at hospital care and dates of admission and discharge. I mean, there's a lot of variables there. So, but we're specifically focused on pediatrics right now.
Ms. Sandler.
And Chair Noor and Representative, thank you for that question. So we have to start by getting the kiddos home, but then absolutely this program looks at how well not only the child is doing at home, but also the family. So our service is very much a believer in the holistic family approach. So we will be measuring as well how effectively are we keeping that child at home, meaning are we able to avoid ED visits? Are we able to avoid readmissions? And then what is the family's perspective? So we invest highly in caregiver training because the days of having 24/7 nursing are no longer. So we want to make sure that we're doing our part as well so that those family caregivers have the confidence and competence to care for their child during the hours we're not there. And we measure that as well through family feedback.
Thank you.
Representative Snicker.
Thank you, Chair Noor, and thank you, Representative Bierman. I understand the program that you're doing this pilot project and support it. My bigger question, when I listen to you, it sounds like the goal would be to assure a continual staffing pattern for the nurse, regardless if the census changes, which I understand the intent of that. I guess I would like to ask if there's any possibility. This is focused on pediatrics, but if census changed, which it will, I mean, having been in 24-hour operations, I will guarantee you it will. So if we're going to allocate $1 million, I guess I would like to see that we have the ability to be flexible to serve other brackets through home care, because we've put a significant investment in home care in the last budget year, which I supported also. I think the concept of what we need is important in those different capacities. But when we're looking at placements out of the hospital, I've been in many of them, and there are complex medical and behavioral needs waiting there. So if we have nurses that we're paying for with a set guaranteed schedule, with a set guaranteed wage bracket, I would hope we're innovative enough that if there's not a child to go into that we can use the talents of that nurse in our community. And I'd like you to address that. Thank you.
Sure.
Representative Bierman.
Mr. Chair, Representative Zalesnikar, thank you for the question. That's a really good question and a really good point. The nurses who are trained and skilled, we want them to be on site with patients who have need. When I toured the pediatric home services and met with nurses and walked through the training that they receive for this, that's fundamentally something that they pointed out, that, you know, with kids especially, you want a consistency and a continuum of care, hopefully with the same nurses over a period of time, so that everybody, including family members, are comfortable with the care they're receiving from that skilled nurse. But when there are occasions where that child or the situation of a nurse, if they call in sick or something, you're going to have a pool that can be immediately put out there to take and fill those spots. And then when you have maybe a surplus of nurses, if we can get to that point, then you are going to want them out in homes in the capacity of which Representative Pryor talked about, extending the reach of this pool of nurses. We're not there yet, but I would like, Mr. Chair, Ms. Sender maybe to speak on that as well.
Briefly, Ms. Sanders.
Yes. Absolutely valid question and point. What we specifically are responding to is the needs that we've heard coming from our community and from our discharging children's hospitals, but don't at all minimize the fact that this need exists beyond the pediatric complex population as well.
Representative Zalesnikar, any follow-up?
Thank you, Chair, and thank you for taking the initiative to get this. I mean, I've been on many of the hospital calls weekly, listening to this compression issue for the last 2 years, and it's real. And we have to do more for the kids, and we have to do more for our adults and for our seniors. So we have a long way to go, but this is an initiative that is important. We just have to find $1 million. So thank you.
Representative Hicks.
Thank you so much for bringing this bill, this pilot piece. I think it's really important. It's really hard to quantify a negative, but anybody who has ever seen how expensive a hospital bill knows that we need to be able to quantify it, because we really can't explain how the spending leads to savings without having some data to back that up. My daughter has a little friend that she met when she was in PICU, and he lived in our local hospital for 2.5 years while they waited for nursing. It's not okay. So thank you for bringing forth what I hope will be a really good step to quantifying the true savings that exist when we meet people where they are and provide care in their home.
Representative Tizotin.
Thank you, Mr. Chair. So my comment and question maybe is twofold. First, I think, this is a really wonderful program. We have some good family friends from church whose son with Down syndrome has a home nurse, and now, and he's 3, so now he's kind of entering this world of early care and learning and figuring out the days that, potentially his nurse could come with him on site in the school district. And I know that there's some challenges surrounding that. Given that this is, mainly more with infants and as kids kind of age and into that, but I would be curious just to capture ongoing, maybe how that interplay happens and how best we can support that, because that's another big transition for families when they bring their child home from the hospital, and then if their child is able to kind of venture outside of the home, even with some of those complications, and be able to get some socialization, education, outside support. So I think that might be a really interesting thing for us to continue to work together on, Representative Bierman. And then I was thinking a little bit about, so Representative Hicks said quantifying the negative, and then what Representative New Burnley said, and just kind of looking at the language. I mean, I think the report would potentially give us the same information even if we took away that eliminated upward because we already know where we are. So then if the report just shows us then where we are, it would be a pretty black and white comparison. So I don't know, as we look at that, we could maybe consider if that even makes things more clear. So just, I don't know if there's a real question there, but appreciate your work.
Good comment.
Representative Bierman, and also with your closing remarks.
Just want to thank the committee for hearing the bill. I've been really impressed with pediatric home services and the work of Mrs. Ender, and I think she's doing really fantastic work that deserves some support, and I appreciate the committee's discussing it and your support going forward. Thank you very much.
Well, thank you so much for bringing the bill forward. So with that, House File 4047 is laid over. The next bill that we have is House File 5228. Representative Virnig, I think I'll move on your behalf House File 5228 to be laid over. Please introduce the bill and proceed.
Thank you, Mr. Chair and committee members. In front of you is House File 5228, a bill brought forward that addresses a missed opportunity from last session. This bill eliminates parental fees for parents with incomes over 275% of the federal poverty guidelines whose children receive medical assistance services in disability or mental health residential settings and makes conforming changes. Last session, TEFRA fees were eliminated for parents whose children are enrolled in straight MA or whose children are accessing home and community-based services. However, these fees were not eliminated for parents whose children are living in children's residential facilities, psychiatric residential treatment facilities, and intermediate care facilities for persons with developmental disabilities. These fees can still create undue hardship, financial hardship for families. And for a family of 4, 275% of the federal poverty guidelines is $85,800 per year. This is less than the cost of living in many Minnesota counties, according to DEED. These fees push families under DEED's cost of living standard in most counties. In your packet, you'll find 2 letters of support, one from ARC Minnesota and one from Legal Aid. Thank you.
Thank you so much. Do we have anyone in the public who wants to testify on the bill? Seeing no one, member discussions? Lee New Burnley?
Thank you, Mr. Chair, and thank you, Representative Virnig. It will be no surprise to anyone that I say this. Frankly, I think it was a mistake to remove all TEFRA fees. So can you just give me a brief, why should a family making $250,000 a year not participate in the cost of healthcare?
Representative Virnig?
I think these are really hard fees to pay for families, and $250,000 a year does not necessarily mean that you are thriving. It depends where you live. It depends how many children you have. It depends on a lot of different things. So student loan debt, medical debt, there's a lot that goes along with that.
Lee New Burnley?
Thank you, Mr. Chair. I'm dumbfounded. I'm shocked. I have not been in a situation where we would say that somebody making $250,000 a year does not have the ability to thrive. That is shocking and far above. That is far outside the experience of the vast majority of Minnesotans. And I suspect that the vast majority of Minnesotans who frankly are making do and doing well with far less would be shocked by that take, that somehow a family making that much money would be in a position where they could not choose to be thriving, and that they could not participate in the cost of their health care. I suspect families making, the vast majority of Minnesota families, by the way, making far less than that might feel differently about that. Thank you, Mr. Chair.
Thank you so much. Representative Virnig, did you want to respond?
No.
Representative Hicks?
Thank you so much. And I really appreciate this. This was something that when we didn't do this piece last year, I was really struggling with. Because the piece that, when we talk about how much it is, I want to be really clear, We're talking about kids that are in facilities. Facilities that parents have to travel to in many cases. Facilities where their room and board is being paid in a different way. Facilities that these costs can be more than a person's mortgage. That is not uncommon. I have heard that from so many families where their fee for their child to get the needed mental health treatment that they need was more than their mortgage. And what happens in many cases, because all of these fees get to be so expensive, is that people choose whether they can afford the care. And when they can't afford the care, what happens is the child gets worse and things cycle. These particular fees for when a child is in a facility are really hard to quantify in the constraints that happen to folks. And when I've heard from families about how challenging this has been for them. And so I'm glad that we're able to work through some of that and support it, because we need to make sure that our families are together, and we need to make sure that kids get the intervention they need when they need it, and make sure that we're doing that across the board for all children, regardless of why they need the care. So, thank you.
Representative Kwok.
Thank you, Mr. Chair. I assume anyone listening would really love to know what the median fee is and what the fee range is, just so that they actually know the ballpark of what we've been talking about. Thank you, Mr. Chair.
I believe we have somebody from the, oh, sorry.
Go ahead.
I believe we have somebody from the department or research who could answer that.
Can see Director Bailey coming down, so we'll give a minute. Please introduce yourself and proceed with your response.
Hi, Chair Noor, members of the committee. Elise Bailey, Budget Director for the Department of Human Services. I don't have that offhand, but I can certainly gather the information. These fees only apply to a very small number of families, only $239,000 per year. And so they're not large fees on the whole, but I can gather that for you.
Representative Kwok.
Thank you, Mr. Chair. As a standing practice, it would be good to actually have this information before the committee members, before we discuss the bill, because I get people texting and emailing me about specifics, and we've had multiple members, and the whole topic here are the fees. So that's something we should really have before us. Thank you, Mr. Chair.
Representative Gilman.
Thank you, Chair. So, quick question. Has a fiscal note been requested?
Mr. Byrd.
Mr. Chair, Representative Gilman, Ms. Bailey just told you the whole cost of it is $239,000 per year, starting in '25. That's the cost.
2, 3. Okay, I'm sorry. I didn't hear that.
And yes, there is going to be a fiscal note coming through. I think we have in the Senate. Oh, yeah.
Okay.
Representative Gilman.
Okay, and then really quick follow-up is just curious again why this was not taken care of last year. I mean, that's what we're wondering.
It's a question to me. I think Representative Virnig was.
Yes, sorry.
You have to wait to see how things are going. In fact, I think we didn't have this whole process ready to go last year.
All right. All right, thank you.
The next person, well, no one else on the list. Your closing remarks.
Thank you, Mr. Chair and committee members. Eliminating these parental contribution fees for parents of children who receive MA services in disability or mental health residential settings will make a positive impact. It means families won't have to choose between paying a mortgage or rent or TEFRA fees. So thank you for your consideration. I renew my motion that House File 5228 be laid over.
Thank you so much. House File 5228 is laid over. The next bill that we have is the Governor's Budget Recommendation, House File 5280. I moved House File 5280, and I wanted to get the department to do their presentation on the bill. Director Bailey is coming down to give us the overview of the bill. Please introduce yourself for the record and proceed with your testimony.
Nathaniel M. Olson, a disability advocate.
All right?
Hi, members of the committee. Again, Elise Bailey, Budget Director for the Department of Human Services, and happy to be here to present the bill and the recommendations from the governor's budget. Before I begin, I just want to give a shout out to the whole Department of Human Services who've spent the last year working through these proposals while we're also implementing the really amazing investments that you passed into law last year. And so with that, I'll get started. So I'd like to center us before we get into the detail of the budget in our mission at the Department of Human Services. So we really strive to work with many others across the state to help people meet their basic needs so they can live in dignity and achieve their highest potential. The impact of our programs are immense. So we serve at DHS about 48% of kids across the state, 27% of adults, 17% of older adults, and 37% of people with disabilities. And of course, the human services system is expansive and includes many, many people, including families, people served, tribal nations, counties, DHS, the federal government, and providers. And before I get into the bill, of course, you made substantial investments in this area last session. So you made important steps to address the workforce crisis in home and community-based services, addressing deep poverty and homelessness, improving equitable access to behavioral health care, and of course, authorizing the Department of Children, Youth, and Families and the Department of Direct Care and Treatment to initiate steps to become their own agency. So we're all working on that as we speak. So a summary of the total DHS supplemental budget package. This slide goes over all of the proposals across DHS, across all of the jurisdictions. So we have 18 proposals, and we're really this year focusing on critical needs. Those include increasing the state's capacity to serve people needing behavioral health care, deploying strategies to assist folks with complex needs to leave hospital care when they no longer need that level of care, reducing opioid overdoses, and creating a new 1115 reentry waiver, investing in vital infrastructure supporting our child welfare system, developing an agile response to emergency needs when they pop up, and providing operational needs as our agency reconfigures into 3 state agencies. So in the bill before you, I will get into the details. We have one proposal on page 3 of the change page document. This is expanding access to direct care and treatment care. The goal of this proposal is to increase the number of behavioral health beds across the state. In this proposal, we have some recommendations that were formed in the Priority Admissions Task Force. Components of this proposal include increasing care to kids. We're investing in the Child and Adolescent Behavioral Health Hospital, or CABS program, to operate at full capacity. Currently, we don't have enough funding to add to the staffing complement that would be needed to serve the full amount of beds that we have. So this portion of the proposal would increase our capacity to serve 8 more beds. We are also increasing the number of people served in a forensic mental health program, or FMHP. We do this by repurposing resources at Care Carleton and Care St. Peter and creating a new FMHP, which would increase our mental health beds by 16. In the proposal, we're also creating a coordination with jails program where we would provide support and technical assistance to the county correctional facilities as they serve folks there. And then we're looking to do future policy development around mentally ill and dangerous commitments, creating a task force to optimize the use of state resources and increase equitable outcomes for that population. The next proposal is on page 7. This proposal is centered around helping folks who are stuck in hospitals. They no longer need that level of care, but there's not adequate resources in the community to help get out of the hospital and thrive in the community. This is a complex problem, and so in this proposal, we have several strategies trying to aim at loosening up some blockages in the system. The first one is providing waiver services in hospitals. This had previously not been allowable under CMS to have something that's paid for under the disability waivers when somebody is in a hospital. Once they enter a hospital, basically the Medicaid program is paying the hospital rates. A few years ago, we had a study on how we could possibly do this because CMS had opened up that flexibility. So this proposal implements a component of that study. It would allow somebody who's on the disability waivers who has a worker, when they enter the hospital for acute care, that waiver worker could also provide care while they're in the hospital. We think that this proposal would assist in the continuity of care and help folks kind of go through hospital level of care quicker. We're also looking to have future policy development around PCA. At this point in this proposal, we don't have that piece worked out, and so we would like administrative resources to continue to work on that to allow at some point a PCA worker to also serve that person when they enter the hospital, and again, help that person have better quality of care, better continuity of care, and then to get out of the hospital quicker in those instances. The second component is addressing the backlog of min-choices assessments. This proposal would remove the current 60-day limitation that is in place for an initial assessment. That would be shifted to 365 days. So an assessment would be available for a whole year without timing out. We would also remove the experience requirement for registered nurses as an assessment requirement. So we're hoping to increase the applicant pool for assessors to lift up some backlogs there. The third component in this proposal is supporting older adults who have complex needs. This is a repeat proposal from the governor's recommendations last year. It would create a new elderly waiver budget cap for folks that have high complex needs and who are eligible for the elderly waiver. This would help people who have really high needs access services in the community rather than having to be served in a facility-based care. Currently, folks who receive services through the elderly waiver program, they have a budget and they have to stay within that budget. And if you have really high needs, it's hard to receive services at that level. And so this would provide additional resources for people who meet that eligibility threshold. We're also supporting older adults in the alternative care program. This proposal would add a service called transitional services to the AC program, which would help people move from a facility into the community if that's what their choice is. And then lastly, this proposal would assist tribal nations in supporting people with disabilities and older adults. We would have funding in this proposal to work with tribal nations to develop a tribal MAVDD benefit, tribal MA, Vulnerable Adult Developmental Disability Targeted Case Management Benefit. Say that 3 times fast. But we're hoping that this proposal would develop a new benefit that would assist tribal nations in serving their populations. The next proposal is on page 15. This is reducing recidivism and preventing opioid overdoses. So we know that people who are recently released from incarceration in prisons and jails are up to 40 times more likely to die from an opioid overdose than the general population. We're hoping that this proposal will save lives by supporting people in jail and prisons as they're exiting corrections so that they have access to services and to mitigate those overdose deaths. We have 2 components in this proposal. One provides ongoing funding for the Bridging Benefits Program, which is a current program that we have where we're partnering with the Department of Corrections. We're partnering with the Department of Corrections where we identify people who are going to be released and they have a really high likelihood of recidivism. And we work with that person so that they have housing and benefits prior to release in order to reduce the likelihood of recidivism. We got funding for this program a few years back, and that funding was short-term. So this proposal is just looking to put that funding into the base. The second part of this proposal is similar to Chair Noor's bill. It creates a new Medicaid demonstration benefit to reimburse MA in jails for up to 90 days prior to a person's release. I'm going to go into a bit of detail about what this proposal does and the details around it. So people incarcerated in participating facilities under this benefit would be determined eligible for MA, and if they are determined eligible, they would have access to a benefit 90 days prior to the release. In the eligibility process, DHS is going to partner with the Department of Corrections, local governments, and tribal governments who are running the local facilities to determine how we would streamline the ineligibility process, and it would occur at DHS rather than the counties and tribes in order to have it go quicker, and so that folks have access to services in a speedy fashion. And then once the person's released, so they would be eligible for this benefit 90 days prior to release. Once they're released, one other positive thing about this program is we would then enable MA, the full benefit set eligibility without delay. And currently there is quite a bit of a delay when somebody is eligible for MA because it's paused when they go in, and it has to be turned back on when somebody's released. And so the goal of this is to have not only access in jail and prisons for that person, but to also ensure continuity of care and that they have access to services and health care once they're released. So the services in this 90-day benefit, it's not the whole Medicaid benefit set, it's a select number of services. It includes care coordination, access to prescription coverage and a 30-day supply when they're released, substance use disorder services, mental health services, and some physical health, family planning, and OBGYN services. The initial phase of this benefit will be in 10 different locations, 3 state prisons, 2 men prisons, and the women's prison in Shakopee. We would have 2 locally operated juvenile facilities, 4 locally operated adult facilities, and then 1 correctional facility owned and managed by a tribal government, or one that has an inmate census with a significant proportion of tribal members. Some other key details. So this is actually a really big change for our correctional industry in that they don't currently bill MA or healthcare for their services. And so collaboration is really key in order to make sure that this benefit does as what is intended as in increasing access to services and ensuring that the person is, better off with this program. So collaboration is key. We're really looking to establish a council in the bill that includes people with lived experience or who are currently incarcerated, DHS, DOC, tribal governments, counties, cities, community partners, and community-based organizations and providers who can all center around developing this benefit and helping formulate how it's implemented. The proposal also requires resources at jails and prisons. So as I said, they don't currently bill MA, and so it will require an IT infrastructure to do so, staffing to do so. And so this proposal includes resources for the Department of Corrections for those facilities, as well as, and I have a typo in here, I think it's 3.75. I might have a typo in there. We do have grants in the bill for local facilities in planning and implementation. Also key to this benefit is evaluation and setting something up from the onset to really measure outcomes, and because we're looking to do this first phase and then at some point roll it out statewide. Future phases could include more locations, more services, and would incorporate lessons learned along the way. The next proposal is on page 38. This is the Human Services Response Contingency Account. The vision behind this proposal is to create a mechanism for the Department of Human Services to act in a more agile fashion when emergencies occur in the community. So it creates a new special revenue account that would enable us to respond quickly when there's an emergency. This is patterned off of the fund that MDH has called the Public Health Response Contingency Account, which is set aside for responding to emergency disease outbreaks. The account in this bill is set up similarly, where we could respond to a human services emergency, and then we would report to the legislature on how the funds were utilized. The proposal also includes on page 69, direct care and treatment separation authority. So there's 3 components within this proposal. One, it shifts the formal separation date from to July 1st, 2025 instead of January. This just aligns with the next state fiscal year. We're establishing the DCT Executive Board, and we're specifying various statutory requirements and legal requirements that DCT would need to have as a standalone agency. On page 48, we have a proposal titled the Disproportionate Share Off-Ramp. So this proposal sunsets a current program called the Disproportionate Share Program, which creates a rate floor for customized living services paid for through the Elderly Waiver Program for some service providers. So this rate floor is applicable to people with lower needs and does not reflect a methodology centered around what's provided to the person. This proposal is fulfilling a previous legislative intent when the program was first put into law that required, once the customized living rates were fully phased in, that the program would sunset. However, there was a cross-reference error in the bill, and therefore the department felt like we could not sunset the program. Absent the rate floor, eligible was for facilities when rates were fully phased in January, they would have received about 45% rate increase on the aggregate, but with the rate floor, considering a rate floor, they would receive 68%. This proposal is ensuring that rates provided to providers are based on the needs of each person and the services provided to them. Some other key budget neutral provisions in our package. On page 28, we have the opioid allocation modifications and sunset elimination. There's a few proposals or a few strategies within this proposal that actually sits in Chair Pinto's committee. So I'm going to highlight the 2 that are relevant to this jurisdiction. In this proposal, we're preserving fees that are currently paid to the state from opioid manufacturers and distributors. Right now, in current law, those fees are due to sunset in 2031. However, we know the opioid crisis is still going and unfortunately escalating. So this proposal eliminates that sunset to ensure that the state continues to have these resources to help fight the impacts across the state of the opioid epidemic. We're also adding the director of the Office of Addiction and Recovery to the Opioid Epidemic Response Advisory Council, or ORAC, as a non-voting advisory member, just because the duties of that office, of course, are very relevant to the ORAC's work. And then on the most exciting proposal is page 72, our budget bill technical cleanup, making various technical changes to last year's bills to ensure that we can carry out what was intended there. I've got resources in the back, links to different resources if you want to dig in deeper. That's it.
Thank you so much, Director Bailey. We do have an 824 amendment, and I would like to move 824 amendment. It's more of a technical in nature. The bill will still be in our possession. Member discussions. Lee New-Burnley.
Thank you, Mr. Chair, and thank you, Ms. Bailey. My questions right now are related to Article 5.
I've got the 824.
Oh, I apologize. Go ahead, Mr. Chair.
Seeing none, all those in favor, please say aye.
Aye.
Opposed, say nay. 824 amendment is now adopted. The motion prevails. So, to the bill as amended, do we want to get the testifiers to give us a brief before we go into member discussion? I do have Mr. Olson. Please come to the testify table. You have 2 minutes, and we will go to the next person. Please introduce yourself and proceed.
I am Nathaniel M. Olson, a disability advocate. So, it's interesting with this bill that as a disability, I have to oppose it. Minnesota House of Representatives, were you aware of something that happened in 2022 in Scott County? There was somebody who had a disability who was reached out there, and I don't know if you know what's happening in the Department of Human Services. We're being taken advantage of. I've had a guardian who told me that I have every right to choose a provider, and nothing is happening. I am sick and tired of reaching out to them and where they're doing nothing. There was somebody who literally was put in jail for almost 96 days in 2022. He had a mental disability. So, Minnesota House of Representatives, what are you going to do? We need to figure out a guardianship plan. There's no guardianship plan in this bill. We need to strike down the conflict of interest. I get so frustrating because I have to reach out to the higher management, to DHS. Dakota County they were gonna investigate, but you know what my group home did? They put it as a behavior. So are you telling me that us disability people cannot have our voices heard because they don't want to get in trouble? This bill is not helping us. It's making it worse. I'll take any questions. I'm asking you, please put a guardianship flexibility grant because our voices need to be heard. I rest my case.
Thank you so much, Mr. Olson, and thank you for sharing your story with us. The next person that I have is Taraji Gorehouse. Please come to the testify table and proceed with your testimony. Please introduce yourself and proceed.
Good afternoon, Chair Noor and Vice Chair Bonner and members of the committee. For the record, my name is Taraji Gorehouse, and I'm a proud member of AFSCME Local 1092. I work as an LPN at Care Carleton, and I've been doing that for a year and a half now. Thank you for hearing my testimony today. I'm here to express AFSCME's serious concern over the proposal to close 2 addiction treatment facilities in Carleton and St. Peter. Our care program in Carleton exclusively serves women battling addiction. We take great pride in being one of the only facilities of its kind. We are the only facility that treats women with substance abuse who are at least 24 weeks pregnant in Minnesota. We have an all-female staff to provide an environment where our clients don't have to fear exploitation or abuse and instead can focus on healing. I know our siblings in St. Peter and the other care facilities feel the same way about their work that they do. We know how important our work is, which is why we have been down here so often this session. We've been informing dozens of legislators about who we are, our work at MSOP and CARE, and pushing for changes to our pensions and letting you all know about the issues our workers face on the front lines every day. We have also been waiting to see the governor's supplemental budget request for DCT. We knew money would be tighter this year, but we were ready to push for what we could get, even if we wouldn't directly feel it at our facility. Any increases DCT might have seen would be worthy of funding because we know that the demand for all kinds of direct care and treatment will only grow in Minnesota. You can imagine our surprise to see that as part of a request to increase capacity for psychiatric beds, the proposal would be paid in part by the savings of closing care at St. Peter and Carleton. We were devastated that we could face losing our jobs, all under the assumption that there was no other way to increase psychiatric beds and that we would all just change facilities and start working at MSOP or move to Wilmer to work at CABS. I speak for many of my coworkers when I say that our jobs are not the same and we can't just get moved around like pawns to shore up other programs. We also want to call out that this is a false choice between expanding beds and closing care. The DCT facility in St. Peter has an entire wing of psychiatric beds that sit empty because we can't staff it. We know how important it is to get those new beds. We know how important our work is for treating addiction, and we know that we have the resources to do both. We hope you see that too and save Care Carleton and Care St. Peter. Thank you guys for listening.
Thank you so much for your testimony. In case of any question, we'll call you back.
Mr. Chair, I do have the evidence base in this iPad if you want me to get it passed around.
Mr. Olson, you can send it to me directly or the committee administrator, so I appreciate that. So
all right, thank you.
If you can wait in case if there's any question, I'll appreciate that. Member discussions? Representative Baker.
Thank you, Mr. Chair. So this is the governor's ideas of helping people in recovery, which is pretty alarming to me. You know, I think no surprises here, I guess. I've got a lot to say about ORAC. I hadn't heard about this before. They were going to take a swing at the sunset elimination again. And last year, with the exception of Representative Virnig, you were not here last year, but I was able to share with members here that a lot went into writing House File 400 with Representative Olson and I. And part of that agreement was the sunset clause that got a lot of our Republican supporters behind this bill that passed 100 and some to whatever on the House floor, 60 to 7 on the Senate floor, because there was going to be a 10-year sunset on this really high fees that we put on pharmaceutical companies with their licensing fees in Minnesota. So we got past it last year. We were able to not do anything, and they're back at it right away again this year because they knew this was a big deal to us as a collaborative body that wants to do it right. So I'm disappointed they bring it back again. I'm disappointed that they didn't, I don't think anyway, maybe somebody from DHS or DC&T can answer this question, but did you ask the ORAC Council about adding the Director of Addiction and Recovery to the Opioid Council? For people that don't know this, I sit on that council. I don't remember it coming up, but right now it's Mr. Drucker is a very good director of the Addiction and Recovery Board. He has had a seat at our table every single time there's been a meeting that I personally invited him to, and he's got a name tag and he sits right at the table with us. He's a non-voting member, but I'm surprised that they want to put him on the board of ORAC and expand the council, which is something that I think we've always been very tightly surrounding and not want to do. What's frustrating about that is that when I asked to have one of our members on his board, I was told flat out no. So you would think that you want to do one here, you might want to go back and forth. This is a problem with the current governor that wants to have it a certain way, but not the other way. Because I think if we want to collaborate, we ought to consider having a member on both sides of this board. But let's talk about care. Let's talk about what we're doing in Wilmer, which has been in the place in works for the last probably 6 months maybe. I could be wrong, but the DC&T leadership came out to Wilmer and said, hey, Representative Baker, we've got this idea. We really want to work on our CABS facility for our kids, the hospital care level of kids. A lot of you know that we've got the 16-bed brand new facility out in Wilmer, the only one in the state of Minnesota. We can only get it up to about 8 beds because of staffing. They came to me with a real concern about let's look at the care facility in Wilmer. We're running out of our lease. It's an older building. Why don't we take this and ramp it down, shut it down, or they called it suspending it, and let's take the staff and try to see if we can get them to go over to the CAB center. You know, that was a hard thing for me to kind of get around because it was a very robust care. It still is. It's about half occupied now because we're working on this transition. But I believed in it because it's helping more kids this way. We can keep the employees working in the same community. Everybody was guaranteed a job, and this was important to me. So doing all that, I even sat with our leadership from DC&T with our employees that were frustrated. Are you kidding me? You're going to shut this awesome program down. They didn't really get their head around we're going to have to work with some really challenging children because of mental disease. But they're coming along, but it's been a lot of work to manage this slowly and carefully, and they are looking for their job offers formally now, but I believe they are very much wanting to help us in that situation. But to close Care Wilmer was a big deal, but I supported it because I thought it was going to be the only one. Now I see 2 weeks ago we're closing down Carlton, and they want to close down St. Peter for the purposes of putting money into an area that we really need, and we've been talking about this for a long, long time. But to come back this year to close down substance use disorder programs for really serious folks, these are locked facilities. These are places you just don't put out in the community providers. You just don't have that. The people in Wilmer, Carlton, St. Peter who have done this, we should celebrate their hard work and what they're trying to do, a lot of times in really crappy buildings, because right now in Carlton, they don't have a good place to do business in. They've got some rooms out of order because the roof is leaking. And we need to do a better job here. So I think we need to tell the governor's idea, this is a horrible idea, about closing more of these down when we just came off of a record spending $71 billion in the state. Folks, we have a lot of things we can do. We could look back at some of the things we spent money on. We spent $25 million for safe recovery and injection sites. I get it. I'm in this world. $25 million. Why don't we take a bunch back from that, still help a lot of people, but it's in this department. We haven't spent it yet. $9.2 million was allocated to new American legal services in DHS for undocumented help becoming documented. We can help people with that. $9 million could go a long way to build us a new facility. This Carlton is special. They're in northern Minnesota. They only treat women. And in fact, the only people working there are women. Because men have done a lot of damage to a lot of people, and they don't want anybody like that coming into the facility. So the folks running it up there deserve our support. I think we should quickly dismiss this bill from the governor's idea of how he wants to help people with substance use disorder. This is not how to do it. We're trying desperately to get people in reentry programs like the chair's bill is. I support that. I don't know that we can do it now, because if they're doing this, we won't have programs for them to go to, folks, if programs like this are going to shut down. So let's get our priorities right. Let's focus on what we need to do. We don't have any money because it was all spent, but we got to find the money to keep Carlton open, to keep St. Peter open. We can't let any more of these close down, and we cannot call ourselves a friend to this horrible disease. So we can do way better than this, and I hope that legislators know that we write the bills, and let's do this better. Thank you.
Chair Fisher.
Thank you, Chair Noor. My questions have to relate around the CARES program. I was wondering if there's anyone from DCT or the department that'd be able to come down for questions as what we're looking at happening with the CARE program.
Someone is coming down.
Thank you, Chair Noor. First of all, some of the questions I have is that currently we are taking care of a lot of people who need services out there in the CARE program. I don't see that need going away, so how will these people receive services? And particularly I'm thinking about up in Carlton, where we have a program exclusively toward women. What is the department's plan to address the situation?
Please introduce yourself for the record and proceed.
Thank you, Chair Noor. My name is Wade Brost. I'm the Executive Director for the Mental Health and Substance Abuse Treatment Services Division of Direct Care and Treatment. Representative Fisher, we currently serve females in all of our programs. They are correct, you all are correct, that CARE Carlton serves only females. So Direct Care and Treatment will continue to serve females, but in lesser quantity than we are today.
Chair Fisher.
Thank you, Chair Noor. So what I'm hearing is that what the plan is that we're going to serve less people in this area and serve more in the behavioral health area, the forensic area. Is that correct?
Mr. Burrows.
Mr. Chair, Representative Fisher. Correct.
What, Chair Noor?
Fisher.
Thank you. What does that leave us in the CARES program? What do we have, and what is the Department of Direct Care and Treatments plan for care as we go forward?
Mr. Burrows, if your last name is correct, is that?
That is correct.
Go ahead, please.
Thank you, Mr. Chair. You are correct, Representative Fisher, that as we look at reducing our capacity in care and repurposing the St. Peter facility into forensic mental health, it'll add 16 forensic mental health beds and allow better access into AMRTC. We'll be able to admit somewhere between 75 and 100 additional patients per year into our hospital level of care. It'll leave us with 32 substance use disorder beds in our system, which is 32 less than it would be today.
Chair Fisher.
Thank you, Chair Noor. Out of those 32, and first of all, correct me if I'm wrong, is the unit that's currently in Wilmer that's closing down is targeted toward adolescents only. Is that correct?
Mr. Burrows.
Mr. Chair, no. The unit that's, the care unit in Wilmer currently serves co-ed, adult, chemical health.
Okay.
Chair Fisher.
All right. No, thank you. That helps a little bit there. My concerns is that this is a population that we know we're going to need to continue to serve. So if we have less capacity, what will be happening to these individuals? How are they going to get services at this level in the future?
Mr. Burrows.
Mr. Chair, Representative Fisher, we'll continue to serve as many people as we can in our 2 remaining programs. We'll have a wait list for admission.
Chair Fisher.
Thank you, Chair Noor. And I guess the reason that I'm asking questions is it feels like what we're maybe doing is people are going to be boarding elsewhere now. So we're just trading. That's just the question I'm asking. It feels to me as we're just trading off populations that are going to be boarding. So instead of having people with mental health boarding, now we're going to have people with substance use disorders boarding. I'm concerned. I appreciate that we're trying to address the mental health component, but I'm concerned that we're just trading one population for another. We may have no net gain. So I'm concerned about the fact that we're robbing from basically it feels like we're robbing from Peter to pay Paul. I'm very uncomfortable with losing out in some of these other spaces.
Thank you, Chair Fisher. I have Representative Kwong.
Thank you, Mr. Chair, and I also heard the same thing, but what I heard were that we're going to, these women that are getting care in a facility, they're going to go on a wait list. And this is a specially designed facility. If we need to build or fix Carlton, we should take and shift. We've got hundreds of millions of dollars we're spending on opulence for the SOB. We could probably, spare a few tens of millions of dollars to actually build a, non-leaking roof facility to take care of where there's obviously a need. But that was not my original line of questioning. It just became extremely obvious from the last 2 people who were asking. I do want to mention we have selected an program audit of the adult guardianship program. And so while that was referenced and will come in the future, we chose that as legislators. We voted for that, and that will be happening for some of the people that showed concern. But my questions are on the budget. How many FTEs are funded in this bill? And there's a follow-up. So
That's a question to Budget Director Bailey.
Mr. Chair, Representative, I can gather that. I don't have it in front of me.
Mr. Chair?
Representative Kwong.
while you're gathering that information, also gather how many unfilled FTEs there were in 2022, 2023, and currently at the present time, because we continue to fund things, or we're going to build other beds and et cetera. But if you don't have the program to actually hire the people to provide the care, because we've got multiple facilities with beds that can't be used because we don't have the staff. And I have a suspicion that there are large dollars in all these budgets for unfilled FTEs. And if we want to help people, we need the combination of the facilities and the people. And I'm not seeing that delineated in this budget. But I do hear about redistributing, we're shifting from beds from here to here, and that shell game doesn't help the people that need it. And that disruption from the shell game actually decreases the efficiency, because you're going to have to train people, shift people. We need to have a plan that is primed at executing improvement, staffing, facilities, et cetera, so people get care in a timely fashion and in the right setting. And it sounds as if we got a special setting that's got some functional problems with the facilities, and we're shifting things around. We need to address the core problems and issues if we're going to make progress. Because I hear stories that tear my heart every session. And I want progress, and I'm not seeing this bill, this proposal, giving me that progress. So when you actually do come up with that information, and previously the median fee and some of the other data that we should have, let the whole committee know and me know. But thank you, Mr. Chair.
Thank you, Representative Quam. I have Representative Clary.
Thank you, Chair Noor. I believe this is directed to Ms. Bailey, Director Bailey, I should say. So what would it cost to expand the psychiatric beds without closing the programs?
Director Bailey.
Mr. Chair, Representative, I can gather that for you. It certainly would increase the cost because we're shifting current appropriations over to pay for the new beds, but I can gather that for the committee.
Representative Clary.
Thank you. So with that, when you get that, can you also indicate what the savings that you're expecting would be in that as well?
Director Bailey.
Mr. Chair, Representative, so we're not expecting savings. We have a current flat appropriation, and we utilize that appropriation for staffing and all the operating costs that we have as running a business. And so we're not attributing savings to this proposal. We're utilizing that current appropriation for the new spending. And the costs of the proposal are the additional costs on top of the current appropriation.
Representative Clary.
One last follow-up. So are there specific issues with the current care program that brought you to this proposal?
Director Bailey.
I will defer to my colleague.
Mr. Burrows.
Thank you, Mr. Chair. Representative. No, the CARE program itself is doing well, but we are faced with tremendous pressures from our community stakeholders, from task force reports, from hospital decompression groups to enhance and increase our hospital beds, right? So increasing access to hospital beds in a time with a low budget and tremendous pressures. We had to make a challenging choice, and that choice was to focus on increasing access to hospital beds while decreasing our residential treatment programs. So we We also know that we've been asked to do this with immediacy. Building a new facility will take us 3 to 4 years before we serve a new person. Repurposing existing facilities will allow us to serve the new group of folks in a lot less time.
Representative Clardy.
Just the last comment. So what I hear you saying is the program's doing well, okay, and Representative Baker was talking about there are already facilities available where services could already occur. So this one I'd really, really encourage you to rethink.
Mr. Burr.
Thank you, Mr. Chair. We actually don't have existing facilities that can ramp up and take on additional capacity. The Anoka Metro Regional Treatment Center is full. We're at 95% occupancy, no additional beds to add. The St. Peter Forensic Mental Health Program, we have 1 unit. We've reduced our turnover rate, reduced our vacancy rate, and have hired, and are anticipating opening that up rather soon. So we don't have existing beds to add service. So that's why we've entered into this discussion about how do we repurpose existing facilities to increase our hospital capacity, and we don't have any other option other than repurpose unless we wait 3 to 4 years.
Any follow-up?
Thank you.
Lead New Burnley.
Thank you, Mr. Chair. And I think Representative Clardy was getting at the question I had, and maybe I'll ask it a little differently, and maybe we'll get a different answer. How much money is currently going into Carleton that will now be shifted to DCT through this repurposing?
Mr. Burrows. Director Bailey, if you have any numbers.
We'll get
Yeah, I do. I just have to pull it up. Sorry. It would take me a few minutes to do the math, actually, but I do have the numbers for you.
We'll come back to that question.
Yeah.
Follow-up question.
Yes, thank you, Mr. Chair. And Director Bailey, I appreciate that. I hope you do. Because to Representative Quam's question, you know, we've asked many times in this committee for how many unfilled FTEs do we have, you know, these kinds of cost questions, and we're always sort of patted on the head and told that we'll get that to you, and I've never seen it. I still haven't gotten that. I mean, we've asked that question multiple times this session, and I have yet to see that information. And that information is actually important to us here around the table as we make decisions. It's really important, and we're not getting that information. It's frustrating. And I would just add, and I appreciate Representative Fisher's comments. And in fact, I have cautioned on this to Chair Noor with Representative Fisher. We need to be very cautious in how we solve this DCT problem, so that we are not pillaging services and staff from other critical areas. And that really feels like what we're doing here by shutting down Carleton and shifting this to DCT instead. We are literally pillaging care for substance use disorder, and not just any substance use disorder, for women, for mothers, for women, 40% of whom are from the BIPOC community in Carleton. And we are closing that down. We are pillaging those resources to shift them to DCT. That is extraordinarily concerning, and I think from the discussion, it's extraordinarily concerning to everyone at this table. I don't think that's partisan. I think that's really concerning to all of us. I am actually really interested to know what that number is, what the cost shift is. And I'm gonna change course just a little bit here and ask about this Human Services Contingency Fund, Article 5. This looks a lot like a slush fund. This does not require a declarative, and maybe I'm wrong, but the way I read this, it does not require a declaration of an emergency. Are there any requirements for this fund beyond the very loose requirements laid out in in this article. It's on page 57 for folks who are looking for it. It's Article 5.
Director Bailey?
Chair Noor, Representative New Bernley. Could I give you the DCT answer first? Okay. So I do have the numbers if we were to keep Care Carleton. The additional cost would be 1.7 in 25, 3.5 in 26, and 3.5 in 28. I couldn't answer the first question because I don't have the numbers of St. Peter, but that is for Care Carleton. To answer your second question, we certainly do not see the Human Services Resource Contingency Account as a slush fund. It is really a way to have an agile response in the event of emergency. You are correct. We don't need a federal determined or governor determined state of emergency because that threshold is extremely high. We did add in the amendment some key requirements of the department. One being to really require anyone who's receiving these funds, and we envision them to be tribal nations, counties, and nonprofit organizations in responding to an emergency, that they would have to detail for us how they utilize the fund, how it connected to people served, and how it was connected to the human service emergency, what have you. And then with that information, we will report to the legislature on how the funds were utilized. So while it won't hit that high level of, a state declared emergency, we are really interested in making sure that it's transparent how the funds are used.
Lee New Bernley.
Thank you, Mr. Chair. If that is your intention, this language doesn't do it. This language doesn't do it. This is so broad. This absolutely is the legislature giving the department money to essentially do anything, to essentially do whatever you want. I mean, when you look at what can be done with this and the reasons for needing it, I mean, health, welfare, or safety of people, that's pretty much anything. That applies to literally everything we talk about in this committee. It can training, coordination, communication, IT, staffing. It can literally be used for anything, but anything not specifically defined by the legislature. And my question is, in relation to this grant, as I look through the appropriations on page 60, it looks like this Human Services Response Contingency Account is specifically being funded under refugee services grants. So how does that interplay?
Director Bailey.
Chair Noor, Representative. So yes, we distribute our grants through budget activities, and the budget activities are kind of defined to each area of the department. And so actually the Refugee Services Grant is the only activity that occurs in the central office. Central office doesn't typically award grants. So it's really about how the agency is kind of structured, and it's the only place we kind of felt like putting it made sense to put, because that's where our central office grant amount is located. It won't be specific for refugee services. It could be a wide range of services, as you noted, but it's more of a function of how our budget structure is, and there's not like a defined place where usually our central office isn't awarding grants.
Thank you, Mr. Chair. How much money is in that is in that fund now?
Director Bailey.
Chair Noor, Representative, I can get that for you. This would, because it's ridered and it would be a special revenue account, it wouldn't be intermixing with any other grant dollars that are currently in that account, but I can gather the other grants that are in that account for you.
Mr. Chair, thank you. I hope that we get the information we've asked for. I question whether or not that will actually happen. I would just really caution the legislature, our body, from doing something like this. And in fact, the numbers we've heard just with Carleton, those numbers through 28 equal less than the amount of money that we're going to put into this slush fund. that the governor has requested. We could just save Carleton instead. We could just save that program, which seems like it would make a lot more sense to me. You know, at the beginning of the pandemic with my position, I was involved in a lot of the negotiations with the department. And I can remember, the DHS was asking for $5 million. Undefined, they could not tell us why they wanted it, what it would be used for, why they needed it. And frankly, it came down to it, we just weren't going to do it. It did not make sense. And as it turns out, and as the pandemic went along, they didn't need it. They were swimming in money from the feds and everywhere else. They were swimming in money. So I have real concerns about just saying, well, sure, here is $10 million, just for, we'll trust you for whatever you want to do with it. And again, we see how broad this is. And to be more agile, for what? We as a legislature have the power of the purse. And I hope that we do not give away our authority to appropriate funds by just creating these slush funds with the departments to do essentially anything they want. I mean, this language is so broad; it literally allows them to do anything they want. And I would add that it's sort of shocking that this is half the appropriation that the governor is asking for, is to just create a slush fund to do whatever he wants. It just does not make sense. Thank you, Mr. Chair.
Thank you so much. Members, we have 6 individuals. We can go over by 9 minutes. So it's up to us what we do. Representative Virnig.
Okay, I'll be fast, sorry, because I wasn't here last year. But I do have a question, something that's specific to Carleton. I share a lot of the concerns. Women who are 24 weeks or further along in their pregnancy, where would they receive services?
Mr. Burris.
Mr. Chair, we would work with our existing care facilities and neighboring hospitals to see if there was an opportunity to serve them in our existing facilities. I believe that what was referenced was admission after 24 weeks versus service after 24 weeks.
Okay.
Representative Virnig.
Thank you. You said that there was no room at AMRTC, but earlier I thought I heard you say you would be adding 75 to 100 people there. How does that work?
Mr. Burris.
Thank you, Mr. Chair, Representative. We have no additional bed capacity, but if we repurpose the St. Peter Care Facility to a forensic program, we'll transfer 16 patients from AMRTC to the forensic program, opening up those 16 beds. Those beds will yield somewhere between 75 and 100 additional admissions per year.
Thank you.
Representative Virnig.
Thank you so much. This is going to be a weird question, but in Carleton, is the idea, because I've heard about staffing issues, that those staff will move to other facilities?
Mr. Burris.
Representative, yes, we want all of our staff to stay with us. We have one large facility, the sex offender program in Moose Lake. We have a couple of community-based service programs in that local area, and then we'd also look at other openings in direct care and treatment. We would do our best to retain all of the staff.
Representative Virnig.
Thank you. In the interest of time, I would have loved to have heard the answer from AFSCME if they really think that they would do that, but I know we're running short. In Carleton, I believe, is that facility subsidizing a local nursing home? And if so, because of the rent piece, what happens to that nursing home?
Mr. Burris.
Mr. Chair, we've been leasing from the local nursing home for several years. I'm not sure if it's subsidizing their income or whether they need us or not. We've shared with them what's in the governor's budget, and they said, thank you for sharing.
Okay, sorry, I have one more,
Virnig.
sorry. So the idea is you think some of your staff will move, and adding 75 to 100 potential people at AMRTC. I noticed, I looked up, sorry, I used to work for Minnesota OSHA, and it looks like you at AMRTC had a serious investigation in 2021 with 20 citations, 19 of those being serious, greater $7,000 a piece. I know it's still not settled yet. That's $133,000. Is that going to have, I mean, it seems like there's some issues there, so adding 75 to 100 people there versus Care Carleton, which I looked up, did not have any citations or investigations in the last 10 years that I could find. Seems to me like maybe we need to rethink the plan. And that's it. Thank you.
Mr. Chair.
Mr. Burris.
Thank you, Representative. We did have some OSHA citations in 2021. Since that time, we've reduced our OSHA recordables dramatically over 2 years, and we continue to decrease. We've increased our safety and security team, we've increased staffing, our vacancy rates lower, as well as our turnover rate. We're doing much better in terms of safety at that facility. So again, we're not increasing bed counts by 75 to 100, we're increasing the number of people served per year. Those are all hospital level patients, which would greatly impact the hospital decompression work group expectations, as well as priority admission task force and our community stakeholders asking for hospital level admissions or access to care.
Representative Virnig.
I'm done.
Representative Snicker.
Thank you, Chair, and thank you for presenting today. My question is, I want to make sure I'm clear. I want to talk about the St. Peter location. If I understood correct, there's a wing right now that has no one in it, and you're staffing up and state that that's going to happen. Can you tell me how many beds right now are not occupied that will be?
Mr. Chair, Representative, there are 14 beds currently not being used. We have increased staffing in our forensic mental health program and anticipate reopening that unit in the coming months. Based on the length of stay in those programs, it's a longer length of stay. So when we open 14 beds, we'll have 14 admissions. It doesn't increase our capacity and access to increase overall hospital admissions, which has been the pressure we've been facing.
Representative Snicker.
Thank you, Chair, and thank you. I have a lot of concerns in this whole package here. I've taken a lot of notes, but fundamentally, we're talking about adding 14 beds in St. Peter, just straight math. 14 aren't in place, 14 will be in place.
Representative
Mr. Burris.
16 additional beds. So 14 that we have within the existing facility that we're staffing up and will reopen without the governor's budget. The governor's budget adds 16 additional forensic beds through repurposing of one chemical health treatment program.
Representative Snicker.
Chair Noor, thank you. To that point, if we simply open the 14 beds with the staff that you've staffed up, that's essentially go and keep the care programs. I've read all this testimony. I am familiar with Care Carlton. I live in St. Louis County. It borders where I'm at. I'm deeply upset to see that we're going to close a successful program that serves as the only place in Minnesota that cares for pregnant women. To me, and yes, you can say they're cared for in other places, but not in a women's only setting. So if you've been abused or if you've had whatever it is, there should be a women's only center for something like this in this state of Minnesota. And so set that aside. It looks to me from looking at it that we would have 14 beds that you're going to have back in service at St. Peter. We're only adding 8 beds in the pediatric lane. And then with the governor's new plan, 16 more beds on top of the 14 at St. Peter. It's just shifting. So my suggestion would be on this DCT and forensic piece that we seriously rethink what we're doing. We are literally creating another problem right before our eyes in this room, and it is going to be devastating to the state of Minnesota. And it's going to further increase the issues that the hospitals are going to face. I have friends that work as security officers in all the hospitals. They are dealing with addictions off the charts. And we are closing 2 successful programs to the points already made across the table and on this side of the table. This is a bipartisan concern, a big red flag. And so on that point, I'm not going to belabor anymore. I don't support this plan at all. And I've spent time with the workers, and I understand what their concern is, and I spent time with family members. And this is a deeply concerning thing to the state of Minnesota for where we're at. My other comment is just the nursing home piece. We've changed the rate base, but it's based on 2017 data. I mean, the rates are not stable. in the nursing homes. And if anyone thinks they are, we're fooling ourselves. So we have 3 sites right now I can list off that with that rate base and changing that whole program, sunsetting that out, it's going to be $1 million loss for Brooklyn Center, St. Cloud, and St. Paul. So we've already lost a significant amount of nursing homes. I'm not sure how many more have to be lost before we go, okay, this is a huge problem. Just like the Care Carleton, just like St. Peter. And then thirdly, it's not a question, it's a comment to say this, this whole thing of this task force. We seem to be in a season of task force, and I've served on 2 of them. But this civil commitments have been up 50%. That's a huge question. I can't answer why. But the fact that this is going to be determining competency determination, it just is a big red flag to me. We have professionals that I would assume determine competency evaluation. A task force, to me, does not play that role.
Representative Snick, I think we have run out of time.
And I will end. Thank you.
All right, thank you. Representative Franson, if you have.
So I will just preference everything instead of asking questions. So I've got an individual that has been been in the mental health arena for 35 years now, and says that the plan to repurpose it as a community-based facility for mentally ill and dangerous is incredibly unwise, unsafe decision to put them that are not ready in the community-based facility. Events like this happening just a few months ago in the community-based forensic program in St. Peter, where a patient at a state-run mental health hospital killed a roommate with a guitar. Also writes that the Minnesota Security Hospital in St. Peter currently has around 30 to 40 open beds that simply need direct care staff hired to utilize them, and to not have these types of beds fully utilized first before even thinking about placing individuals like this in a less secure community setting is nothing short of medical malpractice. And also, I'm reading a letter that was written from MAPE to its members on the DCT closures, published April 2nd, 2024, where they write, "You may have seen the March 18th memo announcing the potential closure of Care St. Peter and Care Carleton and the repurposing of the St. Peter Care Facility for use by the Forensic Mental Health Program to care for patients who have been civilly committed as mentally ill and dangerous. Extremely concerning, significant implications not only on the lives of our patients and clients, but on the lives of MAPE members as well. I do share their concerns. This notice came as a surprise, I find this very interesting, to all of us, and contradicts the previous message received from management last summer when we were told staff would be added and higher quality program and services would be provided at care facilities in Anoka, Fergus Falls, St. Peter, and Carleton. And that the plan addresses existing issues of, nor does the plan address existing issues of staff shortages in forensics and other DCT programs. Members, we have spent, the fiscal year 2024 budget in DHS is $27.3 billion. You know, we have this department that comes in front of our committee time and time again saying, we don't have money, we have to do this, we have to do that. But yet, we never see an accounting of how the money is spent. We are just supposed to believe that the department is broke all the time without ever seeing how the money is actually being spent. And Mr. Chair and members, I really think we need to start diving into where is the money going.
Thank you so much, Representative Franson. I think there's another committee coming in right now. Representative Hicks and Gilman will follow up with your questions in the next hearing. I renew my motion that House File 5280 is amended to be laid over. So the bill is laid over. With that, we are now adjourned.